Hi, I'm Dr. Stephen Masley, and I have a great guest with me today, Dr. James Leiber, a physician in Sarasota, Florida, and currently the only trained Regenexx physician here we've got in the state, and a doctor I see myself. So I'm really thrilled to have the chance to get to talk to you today about what can we do to help with joint achiness, like arthritis and arthritis issues. So I invited Dr. Leiber to join us today to talk about PRP and stem cell therapies and who might be a candidate. So let's just jump right in, and why don't you tell us about these new cutting-edge treatments, and I'd love to hear what you have to say.
Well, thank you, Dr. Masley, for inviting me on your show. I appreciate it. There are lots of people who are suffering with various types of orthopedic ailments, whether there's rotator cuff tears or disc issues in the spine or arthritic knees or meniscus tears and so forth. There haven't been a lot of options up until now in terms of treating these things other than physical therapy, which can be helpful, narcotics, lots of people getting cortisone injections, and then there's this space in between that and having major surgery. And I think that's the space that we're trying to fill, trying to give people alternative options. And we're really looking at tissue preservation strategy rather than cutting. Everything we do is through needle puncture, basically, and image guidance. That is, we're looking at abnormal tissue, whether it's tendon, ligament, cartilage, labral tissue, discs, as I mentioned, sometimes nerves. These are things that we can, with high technical skill, be able to utilize the patient's own healing substances to try and get that tissue to get stronger without having to do a surgical procedure. So that's kind of what we're focused on. And we really use that person's own platelets and stem cells and growth factors. Those are really the players that we're working with. And if you give me a moment, I can explain what those are.
Yeah, but I really like that general approach to trying to use our own tissues to heal ourselves instead of reverting to something like cortisone or surgery, which clearly has some benefit, but also some significant side effects. So I like that general approach.
Yeah, I mean, we want to strengthen tissue. Cortisone, although that gives you some initial relief, and in some instances may be the right thing to do, it also is exactly the opposite of what we're trying to achieve. It degenerates tissue and can do that rather powerfully as opposed to trying to regenerate or strengthen tissue. So, the example I give to patients is typically, if you get a cut on your skin, the first thing that happens is the platelets run to that area and they stop bleeding. And that's really their most important job. And that's pretty much what the medical profession knew about for decades. We later learned that inside of those platelets are these things called growth factors. So once the bleeding is stopped at that cut, the growth factors are spilled out, and there are a whole bunch of them, 7, 8, maybe more growth factors. And each of those growth factors, the way I explain it to patients, they're basically like phone calls to subcontractors. One's calling a plumber, the other's calling a carpenter, so forth. And they're going to bring all the resources over to the area to try and repair the tissue. Interestingly, one of those growth factors has been shown to actually call stem cells. So it makes a phone call to the stem cells. And what stem cells are, they're basically baby cells, and they're just living on ready reserve. They're waiting. They're sitting in high concentration on the bone marrow. There's a lot in fat tissue, and they're kind of plastered to blood vessels in various different places throughout the body. So when they get the call, the stem cells come to that area. They see that there's been an injury. Some of them will quickly volunteer to morph into a skin cell so that the body it turns into the skin. And I think the others, actually, what they do is act more like general contractors. They come in and they survey the scene and instruct everybody else what to do. They bring everybody cups of coffee so that they can function better and perform that task. So over time, without you even thinking about it, you form a scab, little by little, brand new tissue fills in that place. And then you see new skin, and you really don't have to do anything to make that work. Now there are certain things that interfere with that process, and we can talk about that later: tobacco, alcohol, dietary factors, and so forth. But we're utilizing those players: the platelets, which we get from the blood, the growth factors, which we get from the blood and bone marrow, and then we prefer to use stem cells that come from the bone marrow, and a lot of reasons for that we can get into if you'd like. But so through various laboratory techniques and processing, we're able to isolate things from the blood and the bone marrow, put those into syringes that I can then use as an injectable material, utilizing image guidance of some kind. Usually we're using ultrasound and live X-ray, we call fluoroscopy, and with techniques that are typically not taught to doctors in their residency. These are very unique techniques that are sort of in this evolving field. We're able to get into ligaments, into tendons, into joints, and do some really remarkable things. I can tell you this morning, I got a report back. I took care of a 15-year-old pitcher at one of the academies nearby, an athletic academy, very famous place, and he tore his labrum, which is a rim of tissue in the shoulder, and he came to me for a procedure, and we did a stem cell procedure, a bone marrow. He did well. He started to rehabilitate, and while he was rehabilitating, he ended up tearing a very important ligament in his elbow, which a lot of pitchers tear and end up surgery or aren't able to return back to pitching. So his family decided that they wanted to do stem cells on this tear. It was about a 50 to 60% tear of a major ligament on his elbow.
Wow.
So we got him back into rehabilitation, and we just got his MRI results back today. It was about 4 months, 3 to 4 months since he's had the procedure. His labrum is completely healed on the MRI, and his tear is also reported as being nearly completely healed. So almost from 60% probably down to 5% still tear. But that's going to continue to heal over the next 6 to 12 months, and he'll continue to get stronger and stronger in that area. That's kind of the slope of improvement that we're seeing. It starts at about 6 weeks, gets better and better, 3 months, 6 months, and kind of plateaus at somewhere around 12 months. So we're able to do that for a lot of different conditions. And the trick here is doing with honesty and integrity. There's a lot of things going on out there in the field that I think deserve some discussion. A little bit of the Wild West, and we're trying to make sure that we're a part of an organization that's trying to teach other doctors to do this better, so that we can be doing this in a very effective way. And then we need to be realistic with patients, give them realistic statistics, let them know that not every condition can be treated, not everything can be cured. Sometimes we're just managing things. And in some cases, we have to have a line where we tell people, look, this is not the best choice for you. Perhaps you need to have a major joint replacement, for example, and that happens.
Okay.
So anyhow, that's kind of an introduction.
So who would be, that's a really good introduction. I like kind of that analogy that you did with the cut, so it makes a lot of sense. Who would be a good candidate to think about whether they get a PRP, platelet injection, or stem cell? What kind of patients would be your ideal ones you'd want to see because you'd feel confident you could give them a really good outcome?
Well, yeah, we see a lot of these patients. I call them the active elderly, people who have been active their entire life. Now they're 65 years old, and they still want to play tennis. They still want to ride their bike. They still want to go golfing, and they have some sort of a nagging chronic injury, maybe very painful, maybe not, that's keeping them from doing what they love to do. And I think that's really kind of the meat of what I see, and I think those are great patients. Younger athletes as well also can respond quite well. For the question about PRP and stem cells and who gets what, and I think tendon injuries in general can do very well with the type of PRP that we're using, especially if it's more of a degeneration or a small partial tear of a or ligaments such as the ACL, which has been classically required major surgery. We've been seeing some really remarkable regrowth of that ligament. And you could do that with PRP. If it's a larger tear, then I usually will lean somebody toward a stem cell procedure. And we've got some limitations in what we can do with stem cells, which I'll get into in a little bit, but in terms of the FDA regulations within the United States. But with, I think PRP is good for tendons, ligaments, partial tears, and then early, mild, maybe to moderate arthritis can respond to PRP. when we're dealing with PRP is the platelet-rich plasma. It's concentrating the platelets from the blood. So larger tears, large rotator cuff tears, large tears of tendons on the side of the hip, Achilles tendons in the foot. I think it's also better for more advanced arthritis, especially in the knee. People can respond quite well with stem cell procedures. When you get to very advanced arthritis in the hips, that's a much tougher thing to treat, and we have less consistent results with that.
Well, with arthritis, it's not like waiting till it gets so bad you can't stand it. It may be an advantage when it's early to moderate to get it treated, right? So, I mean, here's how I recall you talking to me about when I came to see you for my knee, that once you have arthritis, it's going to, correct me if I'm wrong, but it's usually going to degenerate and get worse by about 5% per year. So over 10 years, you potentially be 50% loss of cartilage and worsening. And by doing stem cells with some platelet and repeating platelets like periodically, yearly, you might be able to stop that degeneration so it doesn't get worse over a 10-year period. I mean, how did I do? Is that close?
Yeah, that's good. You know, I usually tell people about maybe 5 to 7% decrease in the overall volume of the cartilage on an annual basis once that arthritis stops. It's a fair amount. There is some research to show that if you put PRP into a knee joint, in the majority of people, that cartilage loss will be halted for about a year. That's how long the study was, a year. So stem cells probably can do something a little bit stronger than that. In some cases, regrow cartilage to small amounts. If there's no cartilage left, which is what we end up seeing a lot in patients that come to me at that point, well, we're not really going to regrow cartilage. I mean, occasionally I see slivers of cartilage regrow, but in general, we're not going to regrow the cartilage. So we're managing the condition. It decreases the pain. It strengthens the bone. If you have bone on bone, you want that bone to be strong on the edge. Otherwise, it's going to start to get swollen and full of edema. And I think it can be a very effective management strategy. We have a patient who's nearly 60 years old, and she had no cartilage on the inside of her knee. I mean, completely gone. And she came to me with the goal of wanting to complete an Ironman. And she had just started running when she was 50. She was struggling. When I saw her, she had 2 meniscus surgeries and was having a difficult time just even bearing weight. And I said, well, I don't know if you could do an Ironman anyway, but we'll get you feeling better. And in fact, we did the procedures. She trained. She did the Ironman. She completed it. And we did a video on her because it was just such a remarkable story.
It's a great story.
And she did great. She had no pain during the whole Ironman, and she continues to do well. We just have to periodically put some PRP into that knee. And she's now training, or maybe she's already completed it, I don't know, the Escape for Alcatraz triathlon in San Francisco. So, and the point I'm making there is that she still has no cartilage in her knee. So she's able to do these things and so cartilage doesn't have any nerve endings. So, but if you can keep the environment in the knee healthy, you still can function quite well.
Versus cortisone, where you just might cause additional, you'd feel better maybe for 2 or 3 months, but you're actually accelerating the degeneration of the joint. You're doing more healing and promotion for the joint. So really, to me, this is really a breath of fresh air in what we're able to offer people today.
Yeah, and so, I think it's important to kind of discuss a little bit about what is being offered in a general sense. There's a little bit of confusion about some things. Like, I keep hearing patients talk about amniotic stem cells. Have you heard anything about that coming your way?
No. I mean, usually you hear about either bone marrow or fat.
Fat, right. And so we should talk about fat too, but I'll start with amniotic. Amniotic stem cells are kind of hot right now in there's a little bit of some false information that's getting promoted about it. So there are companies out there that are obtaining amniotic and placental material and fluids, packaging this into a vial and manufacturing and then selling it to doctors and say, hey, here's your magic juice. If you inject it into a tear, you're going to have great results. First of all, they have to know how to inject it accurately, but that's not even the point. The amniotic cells, we were kind of excited about it when we first heard about it. We thought maybe these young cells would make someone's older cells function more effectively. So it would take someone's older cells and make them a little younger. And in fact, when Regenexx studied that, it didn't turn out to be the case. The stem cells functioned worse in the presence of these amniotic cells. The other thing that Regenexx did is they did a research study. They took multiple products off the shelf, took it to the laboratory, tested it in various ways, and found out, despite what it says on the manufacturer's label, there are no living stem cells in these products. There are lots of dead stem cells. And something about the packaging process, the freeze drying and the gamma radiating of the product, they have no, so what they do have is a lot of growth factors, and those growth factors are actually less in concentration than what we can get from your PRP. They charge a lot of money for these. They call them stem cells. I've heard of some places, just recently, a chiropractor who hires a physician's assistant. They inject amniotic stem cells and charge $11,000 for it. So I think that's a buyer beware thing. I just want to make sure that your audience is aware about that. And then there's the question about fat versus bone marrow. There's a little bit of a Coke versus Pepsi thing going on with that. And I think there's no doubt that adipose or fat tissue has a lot of stem cells. However, and it's probably about equal to what bone marrow is, even though some people say the opposite. It's not the case. They're about equal. The thing to realize is in this country, there's some very strict regulations that the FDA has. First of all, you can't more than what's called minimally manipulate the tissue, and you can't use it for what's called non-homologous use. You can't use it for a structure that's not related to that fat or bone marrow. With fat, the stem cells are kind of trapped in the matrix of the fat. So you have to break apart the fat with an external enzyme called a collagenase. When you break apart the fat with that enzyme, then you can get the stem cells and use it. The process of adding that external enzyme is considered to be more than minimal manipulation, and therefore the FDA feels that that should be regulated as a drug rather than as a body tissue. And so that would need FDA drug approval to do that, which requires, I'm not saying this is right or wrong, this is just what it is, that would require in this country what, up to $1 billion in money in trials and 5 to 10 years to get to the point of getting a drug approval. So although it's being used commonly in this country, it is illegal according to the FDA, and they just don't have the manpower to go after everybody. So that's one reason we don't use adipose and fat tissue. Another is it is on head-to-head trials. There have been at least 13 of these where the bone marrow has been shown to more effectively convert into an orthopedic type tissue than fat. Okay. And then just overall, there's just way more data right now on bone marrow. Although fat tissue is just, they're starting to collect more and more, and maybe it'll become more important for us over time. But right now, with the FDA regulatory requirements and the data, we think bone marrow is a better way to go. Even though as an organization, we used fat for a number of years, and we had some comparison data and didn't see that fat did any better. So I thought that was important for your audience to know as well.
And let's talk about a little bit of the contraindications. There's things like if you're on a statin cholesterol med or NSAIDs, Aleve, Advil, those adversely affect stem cells. So do give a little bit on that, because if you're on one of these meds, you may have to look at just platelets and not stem cells. So can you cover that for a moment? Because I think that's also an important point.
Yeah, sure. That's definitely important. So, you know, we're really dependent on the person's stem cells, the health of those stem cells to do the procedure. We don't have a drug we're using. So we really spend a lot of time talking about lifestyle modifications in advance of the procedure to try and improve the overall stem cell count. We also measure what percentage of the stem cells are alive or dead. We have equipment to do that. And we like to see that number as high as possible. The more stem cells, the better. So we've been able to identify certain medications that are negatives, certain supplements that are positives, certain exercise activities, and it's just a variety of different advice that we give in advance. So when it comes to medications, we're talking about, we've been able to see in our laboratory that certain drugs seem to inhibit the ability for the stem cells to divide properly into the type of tissue we're looking for. So this is our own internal data. There's some other data about this. So statins is the one you mentioned, and although there may be benefit for statins in certain instances, as far as our procedures go, those statins can be detrimental. So we typically have people do a little bit of a washout period. We like them off of that statin medication for about 6 weeks before, and we're looking at 6 to 12 weeks afterwards off of the medication. Unfortunately, unless you've had a heart attack, there's really not a big deal to be off of a statin for a short period of time. And obviously, we don't mandate that. That's something they have to work with their prescribing doctor
right.
And come up. And we can give them some alternatives that are okay. Some high dose fish oil, some supplements that might help with the cholesterol in the meantime. So for people who can't come off the statin, doesn't mean we can't do the stem cell procedure. We're just trying to optimize every variable we can, and they still can do it. And to be honest, we've had that happen, and we still have had good results. So it's not an absolute contraindication.
Right. Just potentially less effective, but not a contraindication. Okay.
Right. Yeah, and then there are a couple of other drugs that come up. Certain blood pressure medications, angiotensin receptor blockers, and ACE inhibitors, which are typically excellent blood pressure medications. We have found inhibit the stem cells' ability to grow. So that would be, they need alternatives, and we usually give the patient to some options to give to their doctor.
But beta blockers as well.
Beta blockers are a little lower on the list. It doesn't seem to be as negative of an impact. So,
and what about the meds that people take all the time for arthritis and joint aches? Aleve, ibuprofen, naproxen, these, NSAIDs.
Right. So a here and there type of thing is probably not a big deal. But if they're on it chronically, which nobody really should be, there's a lot of negatives to being on that on a long-term basis. That's a negative for our procedure. We've been able to identify through our registry data. I don't think we mentioned that we track all our patients across the country, so we have a lot of information to go by. We've been able to see that people who are taking those medications do worse. So we have a washout period, probably about the same, 6 weeks if they're on it chronically. The other one is if you've had a cortisone injection. Let's say you're coming to me for your knee, but you've had a cortisone injection in your shoulder. I will wait 3 months before we do the stem cell procedure. Yeah. Now the platelets, the PRP, we're not as aggressive about the medication changes. You can stay on your statin. We still want you off of the Aleve, ibuprofen. We usually do about a 2-week time period for that. Aspirin, 2 weeks, 1 to 2 weeks. So it's a little less aggressive. We don't worry about the blood pressure medication either.
Now, I got a question for you. I had a guy in my office this week for one of my, optimal health assessments, and he asked me about donor IV stem cells. He goes, all my buddies are saying this is the newest and best thing, that they're getting stem cells, that they're getting injected with an IV into their vein to just rejuvenate them. I mean, I can guess, but what are your thoughts on this?
I think it's an interesting concept. I think it's not ready for prime time yet. I think, where are they getting the stem cells from?
Some donors. They're just getting them from, not even themselves. I mean, I was pretty surprised. I was like, wait a second. I was saying I wouldn't sign up for that. It's like being a guinea pig.
We consider that to be a red flag. Actually, we have some information about this. If there are clinics who are doing stem cells for everything, IV stem cells for multiple sclerosis, for Parkinson's, for cancer, it's a red flag. So
well, that's what I told him. It was a red flag, and I just no.
The point is, your stem cells, your adult stem cells, are the safest thing we can use. Stem cells are potent, and they can change and turn into many different things. So the safest is to use your bone marrow-derived stem cells. They're already kind of pre-programmed, and they're not going to turn into funny stuff. We also want to put it into orthopedic tissue, and that's pretty forgiving. There's not going to be any real problems with that. Once you start sticking somebody else's stem cells into your bloodstream, we don't really know what that's going to do. And we have seen and heard about cases where it's lodged in the lung, or we've seen people do, there's also people doing fetal stem cells. There was a case report in the New England Journal 2015 where a guy who had a stroke in the U.S. flew down to Mexico, and they ordered fetal stem cells from Russia that came, and they injected this into his spinal fluid,
Mm-hmm.
and 6 months later, approximately, they found out that he had a major primitive tumor in his spine.
Yeah.
We don't know how to control these other things. We don't want to use other people's genetic material, which is in the stem cells. Right now, I think the safest we know about is the stem cells that we have. Now, we have some things we can do with the stem cells that we were doing in the United States, and I know you're familiar with this, is we were growing those stem cells. That's called culture expanded stem cells. We're able to get a pure stem cell from the bone marrow, and then over a course of weeks, after doing genetic testing of the material, make sure they were healthy and they would grow properly. We can grow them up to 1,000 times what we can get by just taking them out. In the United States, we have to use your stem cells within 24 hours. But for about 5 to 6 years, we were allowed to do this, and we were growing them to large quantities, collecting safety data, publishing on that, making sure this was a proper procedure. We've been doing it for 12 years as an organization. But the FDA, again, same sort of thing that I said about the fat tissue earlier. The FDA came in and said, if you grow somebody's stem cells, they want that to be regulated as a drug, and therefore that would require FDA drug approval. So Regenexx moved that to the Cayman Islands, and we have a facility there. I'm licensed down there as well. So once it's down there, we are able to do these culture procedures. We can do more with it. We can treat lots of body parts at the same time. Yeah. So there's some interesting things going on with that.
All right.
I think that's the most powerful procedure available at this time.
So we've talked about who might benefit and what platelet injections and stem cells are and what might be contraindicated. And I really appreciate your words of caution on this. I think some people, we get too excited and ahead of ourselves. And I'm really looking at focused orthopedic indications as probably our best use of this at this time. And let me share my experience. I went to see you because I had arthritis in my knee. I had blown out my knee skiing. I'd had 5 surgeries. It used to hurt to walk around and go on vacation and walk a lot. And, I was looking at, well, how many more procedures was I going to have? And since I did that, I'd say my knee got 70% better. I won't say I'm a spring chicken anymore, but it doesn't hold me back. It's not preventing me from doing anything. I've had a really good result, and I've been really happy with it. So I think it's a great option, a lot better than having your knee replaced, for goodness sake. So I'm grateful for it.
I did a talk last night and spent a lot of time talking about the statistics related to major joint replacements. And, they may be the right choice for some, but I think we really, as a country, need to reduce the total number of these that are happening. Right now, the projection is an increase by about 600% of knee replacements by the year 2030. And the largest age group is the 45 to 55 age group. Very likely want to remain active, and they're very likely going to need revisions once or twice, and those are bigger surgeries. And, I don't think all of the risks associated with these major surgeries get clearly stated to the patient and understanding what the risks are. If you're over the age of 60 and you get a major joint replacement, your risk of having a heart attack or stroke within that first 6-week period, so it's a limited time, but within that 6-week period, is anywhere from 25 to 30-fold from if you didn't have the surgery. So we're talking about 2,500 to 3,000% increased risk of a heart attack or stroke. That's the big ones. Then there are a lot of other more, I say, minor risks in terms of infections, which can get really serious, and blood clots and limb length discrepancies. You can have different, and that can cause other problems. There's all sorts of things. But maybe about 20 to 30% of patients have something that would be considered to be a complication in some way, including pain for knees. People with very advanced hip arthritis who have a lot of severe pain, they seem to do fairly well with hip replacements. But people with knee arthritis don't do nearly as well as those with bad hips.
Okay.
And we're trying to give those people, just another option. And so I think your results sound about average for what we see for the type of condition you had. Now, you must have had some meniscus removed at some point. And
4 different times.
So what we're finding, the data is, this is not our data, this is the orthopedic literature data, is that every time, a meniscus surgery seems to accelerate the arthritis quite a lot in the knee. So you're kind of pushing your way toward a knee replacement more quickly. And then, when they've done these surgeries, they've compared it to like sham surgery, where they go in and pretend to do surgery and they don't. And compared that to doing a meniscus surgery, they find that the fake surgery does as well as the surgery. And then when you compare it to exercise in different studies, that a really skilled exercise program, rehab program with a physical therapist in the long term does just as well as these surgeries without causing that accelerated arthritis. So I think doing these meniscus surgeries really have to be limited to very specific indications.
Okay. Well, I'm glad to have this new option that's available and seems to be cutting edge. So how could people, learn more about what you do and your location, and how would they find you if they were looking to get additional information?
Yeah, I appreciate that. I think if someone should go online, and there's a lot of information on there, I think they should do their research, look at various different sites. Regenexx, it's very easy to find that. You just type in the word Regenexx, REGENEXX.com. There's a ton of information there. All the research that's been published by Regenexx is on that site. All our personal registry outcome data is also put into graphics for patients to see. There's blogs, thousands of blogs reviewing research over the last bunch of years. And then our personal website, which is closely linked with Regenexx's corporate website, is newregenortho.com, NEWREGNORTHO.com. And there's a lot of information that can be found.
I think you cut out there. Could you just say that again, your website?
Yep. Our website is, the name of my organization is New Regeneration Orthopedics of Florida. And so our website is newregenortho.com, NEWREGENORTHO.com.
Okay. Well, thank you very much. I really appreciate the two of you sharing your expertise today and us getting to share some information I think is fascinating and cutting edge and really the future. So, Dr. Leiber, thank you for joining us.
Okay, thanks, Dr. Masley. I appreciate the time. Take care.